200. This chart is the same. For the LA on the board. But I want to explain you about history of present illness, time history, contact history. What is it? Contact history. Contact history. Living close to like in household, history. Grandmother, grandfather, or sibling, or parent. If they have chronic disease, like tuberculosis, grandfather or sibling has tuberculosis, so contact history or tuberculosis, contact history. Like the antenatal history, you ask the mother about during pregnancy, before delivery. How many times they go to the health center or to the hospital for antenatal care? Do you know how many times?
Almost 5 times. At least 5 times.
At least 5 times. The policy of the ministry of health or not? I have 4 times. Before 2 times only, but now 4 times or 5 times. Antenatal history. We ask her about history during pregnancy, in antenatal care in hospital, what they do, what the medical staff give to her. History begin from the labor, from the first stage of labor until delivery, birth history, and postnatal history after delivery up to now. What happened? Any syndrome, any disease or not? Development history about the growth, the growth, especially for 5 months, for 12 months, or 30 months. At 5 months, do you know what is the normal development of the infant at 5 months? Double of the birthday. 5 months. And what about at 12 months? How is the normal development average? Triple. See? And so on. Dietetic history start from colostrum given at delivery, and then what they give to the infant till now, especially for the breastfeeding, exclusive breastfeeding from the delivery to 6 months, and from 6 months to 24 months, what they give? They give complementary food. Complementary food composed of rice, meat, pork or beef or chicken or fish, and vegetable, green vegetable, red vegetable, green vegetable, nobody about the red vegetable, and also fat. We should add 1 tablespoon of fat. But Ideal, we want to add vegetable fat. Vegetable fat. If not, you can give the pork fat. And family history about the health condition, how the sizing, how the parent, how the grandparents, they are living together in the same household. And socio-economic history. This is a little bit difficult, but we can mention about the green transportation. The green transportation, how each household they have motorbike or bicycle or a car, private car. We can judge about the bill of the family. In the provinces, the NGO support for 80 fund in the province. Very good. You heard about APT fund in hospital? Do you? What? Who know about APT fund in the hospital? The NGO support the free of healthcare for the poor people. Support free of healthcare, and also the support for the funeral of the poor dead people. Funeral, and also the green transportation from the house to the hospital for the poor people of the wind. But they apply assessment, APT fund assessment. They have to check this, and they send their staff to the countryside to assess the real scene of the people. And when they check very poor or poor, they will deliver a card for 2 years or 3 years. When they go to the hospital, all are free for them, free for health care. About social history. Immunization history. Who are working in health center now? Who? You? Working in the health center? I ask you about immunization. How many vaccines are available in your health center? Tell me by order.
BCG.
Ibadah. Please tell me. First is what?
It's also
You know? Yeah. So, please.
first letter.
BCG.
We can also carry a calling number.
Ôi dỗ vậy đó. OPV vaccine.
That's it? That's it? FITB. And the third,
Diphtheria, malaria, tetanus, Japan encephalitis, rubella,
really?
chea.
Mia,
Really?
yes,
Yeah. 1, 2, 3, 4, 5, 6, 7, 8.
nơi một cốc, men ăn của cốc, rubella.
Anything else?
Chea.
Oh,
Chea.
yeah.
Cục chê tốt mát, cục chê tốt mát.
Anything else?
Mắm,
That's it? Really? Sure. Sure or not? Thank you. Now we have the third.
HPV.
Now the WHO asked Cambodia to buy yeah, expensive. One shot costs about $30. One shot.
Rota rồi thế. Phân trộn. Xong trộn vào. Đi khi rota. Rota rồi vậy.
I will prepare the slide for you. Yeah. About the immunization. We ask
Yeah.
not get complete or drop out. No? If we immunize either
Kẹt
nine
này vẫn
months old, yeah. Less than 9 months old, we ask about complete or not. And after 9 months old, ask again if they drop out or not. For history of allergy in pediatric, very rare for history of allergy, but we must mention about allergy. Is it the standard? Over the world, they mention always allergy in medical section. Even independently Israel. Allergy for food, allergy for drug, no? Allergy for food or for drug. General examination, ear, nose, and throat. Skin, spine, and cranial. Spine and cranial. See? Spine, you mentioned about the spine, or cervical spine, thoracic spine, or lumbar spine. And also the cranium sometimes, the posterior of the head subsists more long term, maybe more than 2 years or 3 years. That means Rickets syndrome. Rickets syndrome. And vital sign, vital sign about temperature, respiratory rate, heart rate, and so on. Anthropometry data about the length or the height. If the patient age less than 2 years old, they cannot stand properly for mid-urine. So measuring the length. And also the weight, if necessary, we calculate our body mass index. And developmental assessment. We have the plot in the yellow card. You see, in yellow card for infant, they mention about the age and also the weight. Systemic examination, cardiovascular system, respiratory system, you consultate the heart and the respiratory system and the lung. You refer to the copy I made for you about the sound of the abnormal sound, normal sound of the heart, and also the lung. You receive it? Because if I now I do again. Now, nervous system. Nervous system concern about the normal medical section of the reflex. Or the small child about the primary reflex. And now the reflex, where you can throw for deep reflex. Where? You see the big outlet, and you draw a chart. See?
Dysphoria, cross-fat nature. Cross-fat nature. Dysphoria. Dysphoriaជំងឺខាន់ស្លាក់យកមួយទៀតអត់
nervous system, and you give a provisional diagnosis, and you ask investigation. What lab test, ultrasound, MRI, and after getting the result, you take the diagnosis or you change final analysis and design. That's it. Do you have any question? If not, I go to the SOET medical solution. This is very important, especially for medical students from the French-speaking university. They don't know. For English-speaking, they know. Very simple and very complete. Simple, short and complete. Before hospitalization, the patient go to the OPD, outpatient department, for medical consultation. And the doctor in medical consultation, the doctor in OPD, they never use the medical record. No. They use a special form, like a SOEP. SOEP, clinical solution, acronym, subjective, objective, evaluation, planning, and subjective and objective. They make subjective, objective, no, subjective. See? SOEP is the acronym and it is the most simple and easy method to develop for presentation. S stands for subjective. It is the summary of what? Main complaint, the history of illness, background illness. You just to list very short and you select clear to express, very short. After that, subjective is informed by the parent, informed by the mother, informed by the father, or if the patient child is older, 10, 11, 13 years, they can tell you, and you write down on the SOEP sheet. Objective, more concrete, more clear, because everything done by you, you are the doctor. The summary of clinical examination done by physician. Everything, just to list, one by one. Evaluation, that means the summary of diagnosis, maybe probable diagnosis, or differential diagnosis, or if you know possible complication, you can write down possible complication. That's it, SOEP. Very simple, very easy. Do you understand? So I show you one more time. Not yet finished. Sorry. P. Summary of case management. Case management. The management is only the treatment, but also under intervention like the lab test, like the possible referral, like the monitoring plan. That's it, the plan. And you request lab test and other possible investigation like the X-ray, ultrasound, MRI. Treatment, good treatment, maybe probable treatment, but correlate with the diagnosis, possible referral. So you cannot manage the case at your hospital. You should refer to the higher level. Example, you are working in health center in district referral hospital. You refer to provincial hospital or to the national level. Monitoring plan. You can success monitoring plan. Even in your hospital, even you refer to the higher level, you can success monitoring on the way. You know, monitoring on the way, on ambulance, on the car, maybe, yeah, even on the plane. Okay. And this OEP is not done. It's not only done in the OPD or in the form referral to a higher level, but also you apply daily monitoring out the internet in the hospital every day, day by day. You apply the same OEP, but sometimes maybe more concise than on the application. Concise is short, maybe shorter, yeah. And I present you the model. Here, this SOEP 10 years ago, in year 2005, 12 years ago, I am enrolled in one international organization. I would retire on 2006, but I resigned from the government work in 2005 to work in international organization based on in Cambodia. I improved 4 hospitals, 3 district hospitals and 1 provincial referral hospital in Cambodia. I use this to present to the doctor, to the medical assistant, introduce them to know and to use 12 years ago. And now the model. Here, the model. In the name of the patient, subject 59 months female. Here, subjective. The mother told you, fever, they fast, 5 days ago. Headache, anxiety, sleepiness 1 day. They take for cold. They fall 4 days. I paracetamol. Treatment before. And when she see you, objective, you weigh the child, body weight 50 kg, respiratory rate, pulse, pressure, blood pressure. No? Very simple. And you at the time, if we meet our non-give fever, you do the duplicate test, positive. Hematocrit 22, blood line 90,000, 2 millimeter. And you suspect dengue hemorrhagic fever grade 1. Suspect in your evaluation. and you give the differential diagnosis. You give differential diagnosis. Maybe dengue fever, maybe typhoid fever, maybe leptospirosis, malaria. About the plan, you give oral rehydration, bioisolation, 1,000 milliliter a day. Yeah? Yes.
Classify the rate of dengue.
Or the red.
Yeah, the rate, the most
Oh, easy. After the end, I will tell all of you. Easy. Yeah? Very good question. Very easy. How? From the plan. Continue. Paracetamol, 200 milligram. QID, 4 times daily, temperature equal 39 or more. Close monitoring for sign and symptom disturbance. You know, sign out circulatory disturbance. How blood pressure and acidity, and fatigue, and daily capillary hematocrit detection. You do hematocrit every day. That's it. And you sign. You can refer the paper to the higher level because in the hospital you cannot manage, you cannot have crystalloid for the crystalloid and also colloid. You don't have. And we refer to this paper. Not referral with the name and the diagnosis. No SOEP incorrect. We have the question. I explain about the grade to him and to you. Then he evaluated paper. There are 4 grades. They give evaluated paper 4 grades. Grade 1. Grade 1. Now we have the lab test only, lab test, thrombocytopenia, from 100,000 cubic millimeter. And grade 1. Why grade 1? Grade 1, duplicated positive. So, the patient have no spontaneous bleeding. Do you understand spontaneous bleeding? Yes. Like the PKE, and bleeding, gum bleeding. No bleeding. PKE considered as spontaneous bleeding. PKE or pupilla. Spontaneous bleeding. Gum bleeding or no spontaneous bleeding. Grade 2. But at the side, we have at the side, but the summarize for you. Grade 2, spontaneous bleeding. You have already hematocrit 42% or more, you know, thrombocytopenia, and you have the fever also, huh? But I summarize. And grade 3. Grade 3. Grade 3, what is this? Grade 3. Grade 3. Unstable. Unstable that means fast, weak and fast out. Weak and fast out.
Unstable region before curve your vital sign.
Well, focus on how and blood pressure.
Hypotension.
And grade 4.
Something more than what she said.
Shock, there are two. Compensated shock and uncompensated shock. Or no blood pressure, or no pulse. What is it? A mode dynamic. Unstable. Fast, injury or habit, cold hand and cold feet, cold hand and cold feet. See? Shock. About hematocrit supposed to be included in that, but I summarize to be not confused, not confused. Now, BC, another little look. Medical examination of the preschool children. Or sit on. Turn on. Turn on. Yeah.
Any health or developmental problems that might impede a child's success in school. As with any office visit, a thorough history must be obtained. This history should focus on factors that might put the child at risk for problems in school. Such risk factors include prematurity, exposure to drugs or alcohol in utero, central nervous system infections, chronic disease, and recurrent otitis media. Also ask the parents if they have any concerns about the child's development and ability to perform well in school. Growth should be assessed. Height and weight must be obtained and plotted on a standard growth chart. Also obtain a hemoglobin or hematocrit at the end of the examination. Any nutritional deficiencies should be addressed since they are frequently implicated in poor school performance. Obtain a specimen for dipstick urinalysis as a general screening tool for metabolic disorders or kidney problems. Measure and chart the blood pressure. Review these results with the child and the parent. Immunization status must be determined. Schools have the right to exclude children who are not up to date with their immunizations. Ask if the parents have the yellow child immunization record and any forms to be filled out for the school, or need other documentation of the exam or vaccinations. Next, the child's vision is checked using a Snellen chart or a Titmus machine. This testing also provides an opportunity to evaluate the child's ability to follow directions. If you are unsure if the child understood what was expected of him or was uncooperative, ask the parent if the child shows signs of difficulty seeing at home, such as sitting very close to the television or squinting. If the parent has no concerns, chart the results as questionable and retest in 3 to 6 months. If the parents feel that the child may have some visual problems, referral is indicated. Then audiometry is performed. If the child has had frequent bouts of otitis media, a conductive hearing loss may be present. Decreased auditory acuity may in turn result in delayed language development and poor school performance. Again, if you are unsure if the child understood the instructions or if he was uncooperative, ask the parent how she feels the child hears. Does he turn the volume of the television up and complain that he can't hear at the level that everyone else can? If not, chart the results as questionable and retest in 3 to 6 months. If you or the parent have concerns about the child's hearing, referral is necessary. Also assess for developmental readiness for school. There are many different tools for this. One of the easiest is Draw a Man. This tool allows you to assess the child's ability to follow directions, his attention span, as well as his fine motor skills, including how he holds the pencil. Ask the child to write his name, if he can. Does he know his letters? Does he have sufficient fine motor control to write legibly? Ask him to identify several colors. You may use objects around the office. This gives evidence of verbal ability and clarity of speech, as well as of basic knowledge and development. Here, the child is identifying the yellow pen and the black pen. Before starting the exam, always first wash your hands. The sequence of the examination usually can follow that of an adult, although any painful procedures, such as hemoglobin assessment and immunization, should be left until the end.
Hold that, and then we'll just set this right.
Always explain to the child what you are going to do. Allowing him to hold your stethoscope or a tongue blade may help him feel more at ease. First, assess the head. Check for masses, lesions, and also for pediculosis. This is a very common condition in children in school and daycare. Many school days are missed each year due to lice. Since children must be excluded from school until they are knit-free, caution the child against sharing combs, hats, and other objects. Examine the lymph nodes and the foot. Evaluate the conjunctiva of the eye. Conjunctivitis or pink eye is also a common condition in daycare centers and kindergarten. Assess direct and consensual pupillary
I just want you to watch
response
this as I move it, okay, without moving your head. Okay, we're
and
gonna go over here,
extraocular
here,
movements.
and then back over here.
A child of this age should be able to keep his head still
How to do
while
this,
following
huh?
the moving object with his eyes.
Up and down. Okay, I'm gonna look at it right here again.
Check
All
for
the way in.
convergence
All the way
and
in.
accommodation.
All right, good, okay. So what I want you to do is this.
The cover-uncover test remains an important part of the examination in this age group. If strabismus is not detected and treated before 9 years of age, extensive visual loss can occur. Strabismus may also be a marker of other ophthalmologic or systemic diseases.
The next thing to do is, what I want you to do is just look over here.
Finally, a fundoscopic exam is performed.
Okay, you looking over the spot?
Again, a child in this age group should be able to follow instructions and cooperate during this examination.
Because I can't see the line. There it is.
Next, the otoscopic exam is performed.
Here.
Show the child the otoscope with its light. If the child understands that all you are doing is shining a light in his ear and looking, he is generally cooperative.
You could say we're going to do the other one the same way.
Okay. So the next thing we're going to
Check
do
the
is
nares
nose,
for
right?
patency
Check the-
and visualize the mucosa.
That's it. And the other side? Yes. See if you hit that just a little bit. I'm not going to use a speculum. Is that okay for you? Can I get by with that? And then look. Okay, good.
When examining the mouth,
Nose. And we
pay
have-
particular attention to dentition.
There. All right. Let's have you first look up and smile really.
Many children in this age group are already starting to lose their primary teeth.
You do?
Do some
Okay,
silver fine.
good, all right. So you stick your tongue out at me? Like, okay, open your mouth real
The
big.
importance of good brushing and flossing, dental visits as recommended, and healthy snacks should be
Okay,
stressed.
what I'd like to do is just use this for a minute, okay? So I just want to look over here to the side. Can you open your mouth?
You get him to look towards.
Examine the mouth
Maybe look over
So
thoroughly.
we can see what.
You may use the tongue blade.
Just a
There
tap.
it is. I think that's what it is.
Turn the whole head. Hold his head. There you
There
go.
we go. Okay,
That's it.
now.
There you go.
Oh, perfect.
Yeah,
Okay.
yeah.
Now, let's look. Oh, look at that.
Check the gums and buccal mucosa for any lesions.
So let's see, good. Now say, good. Now you can see the tongue open up real.
Examine the nose and the thyroid gland. Checking for any masses or areas of tenderness. Some children of this age are quite modest. If so, try to keep the child covered as much as possible. This is especially true if there are several siblings in the room during the examination. Assess the heart in the sitting position. Palpate for the PMI. Palpate for thrills and observe for heaves. Again, observe the skin for any lesions or abnormal markings. Auscultate the heart. Use both the bell and the diaphragm. Auscultate the lungs using the bell for the apices. Have the child take a deep breath through his mouth and listen throughout the inspiratory and expiratory cycle. Use the diaphragm for the lower lobes. It is never too early to talk about the risks of smoking. During the lung exam is a good time to do this very important health promotion teaching. Examine the back. If there are abrasions, lacerations, or bruises anywhere on the skin, ask the child how they happened. Ecchymotic areas on the back, buttocks, or back of the legs are especially indicative of physical abuse. If the child's story doesn't fit, consider abuse. Check the posterior thorax for respiratory expansion and percuss and auscultate the lungs. Have the child lie supine and listen to the heart again with both the diaphragm and the bell. Explain what you are doing and listen in all 4 valve areas. Again, drape the child carefully. Inspect and auscultate the abdomen. You might allow the child to listen to his own heart while you percuss and palpate the abdomen. Children of this age enjoy listening to their heart. This distraction can prove particularly helpful with the ticklish or apprehensive child. Remember to inspect the abdomen, then percuss, palpate lightly or masses, or areas of tenderness. Sometimes the child will need help understanding what he is listening to. Continue the abdominal exam with deeper palpation. Bending the child's knees may help relax the abdominal muscles. Palpate for the liver edge and palpate for the spleen. Check the femoral pulses and compare with the radial pulse. At this time, the genital exam can be performed, as was demonstrated in the 6-month-old portion of this video. The child who is starting school will be going out into the world without his family and coming into contact with many new people. It is important that he understand what appropriate touching is and what to do if it occurs. Explain to the child that it is okay for you to examine him because his mother or father is in the room with you. Perform a brief musculoskeletal exam. This is a time when many children start to participate in team sports, so it is important that any musculoskeletal problems be detected and treated in a timely manner. Check the reflexes. Explain to the child what you will be doing and that it will not hurt. Again, the plantar response is the same as that of an adult. A Babinski response at this age would be an abnormal finding. Inspect the toes and the feet for lesions. Reflexes of the upper extremity are elicited, again checking for equality. To check motor coordination and cerebellar function, have the child touch each finger to the thumb of the same hand, or touch the index finger to the nose and then to your finger. Note how much more difficult these tasks are for a child of this age than for the school-age child in the next portion of the video. Now, back for abnormalities and lateral curvature of the spine. Palpate the spinous processes for any tenderness. Again, you are inspecting the skin of the back and the buttocks area. Have the child bend forward and assess for any asymmetry as the child slowly stands erect. The rhomboid, standing on one foot, and different types of gaits can give further information about neurological status. Note the differences in the ability to stand on one foot of the children in the preschool, school readiness, and school-age portions of this video. As always, share your findings with the family. Answer any questions and address any concerns. Safety is an extremely important issue for this age group. Pedestrian safety, the use of bicycle helmets, seat belts, or booster seats in the car, and safety rules regarding strangers should all be discussed with the child and family. Remember to discuss issues related to nutrition, dental care, immunizations, appropriate caregivers and sitters, as well as addressing concerns that the family may have. This completes the school readiness physical.
Now, for medical section, finish. I want to continue without break. Do you? Just on. Yeah.
Break the eye.